Yep. Okay, that's very good. So what I'm going to do is I'm going to just cover the issues relating to diabetes, bring you up to date on what is published recently, and also what is expected very shortly. But as you know, the research work that's been done in a number of centers around the world covers other areas like osteoarthritis, heart disease, and there are new publications there as well. So if you're happy with this session today, there's absolutely no difficulty with giving you another update in other areas, should this be your wish. So let's move on. My disclosures, as you've just heard, I was the medical director at Cambridge Weight Plan till March 2019. I now chair this European industry group, the function of which is to deal with legislation in relation to this type of dietary intervention. However, we do have a platform, and if you're interested, what I've done is I've put up various links here. By the way, when we've completed this exercise, you will all receive, excuse me, you will all receive a file which will give you the web links to all of these sources, and I've selected the appropriate ones for you here, colleagues discussing some of the trials, and then also I've written summaries of some of these papers, and these are available online for you to read and to copy if you wish. What I'm going to do today then is a brief introduction. I'm going to refer briefly to the work we started in Copenhagen in 2007, and then describe the direct trial, the diabetes remission trial, and then the preview diabetes prevention trial, and then the droplet trial on GP referral to community delivery of total diet replacement, and then summarize. Now, I can go very quickly through the first slides. I always stick these slides on because it's useful to have them there for reference, because it defines what we're talking about with total diet replacement, an entire replacement of conventional food with formula diet. Low energy liquid diet, most of the experimental work has been done with 800 calorie diets where we're giving 4 portions of formula products. This is the huge portfolio that we now have on this type of diet. We know what it does. We know that it's safe. We know that it's cost effective. Very low energy diets, less than 800. Most of the experimental work has not been done with this lower energy intake. And then, of course, we also have a defined product category of meal replacement products. It's important to know what the definitions are. How do they work? Well, again, as many of you know, we have looked at this slide before, but it's important always to remember how it is that they work, because you may well be asked by your clients or patients, how is it that this type of diet does this? It's, of course, partly because of the larger energy deficit, where it's a deficit of 1,000 to 2,000 calories per day. And that, of course, compares to the conventional dietetic reducing diet, which achieves a deficit of 500 to 600 calories per day. And this, of course, delivers a greater rate of weight loss. Typically, it's about 1.3 kilograms on average in women and about 1.5 kilograms per week in men. So 1.3 kilograms per week in women, 1.5 kilograms per week in men. Now, we also know that because of the rapid weight loss and the rapid changes in individuals and the way that they feel better very quickly, there's very high compliance with this type of intervention. And in the recently published preview paper, we showed that it was 91%. So we know that 9 out of 10 individuals can follow this type of diet for about 8 weeks, and we know that from the direct trial that people were able to follow the diet for 12 to 20 weeks. So that's very, very high compliance indeed. We know that better weight loss in the initial weight loss program results in better weight maintenance outcomes, and there was already evidence for that from the Diogenes trial that was published in 2010. Facilitation of portion control was long recognized by the American Dietetics Association as a mechanism. And then the Australian group in Melbourne showed that the appetite suppression caused by ketone bodies in the blood, that is the beta hydroxybutyrate and acetoacetic acetate that are in the blood at higher levels when you're on a low energy intake, that suppresses the rise of ghrelin, the gut hormone that signals hunger. It suppresses the rise of ghrelin when you are using this type of diet. So we understand the mechanisms and how they work. Nutrient composition, I'm going to skip over this because this is enshrined in legislation. You can come back to this afterwards if you want to. And I'm just going to start now with one paper or 2 papers from Copenhagen, looking at the osteoarthritis trials in people who were heavy older people with knee osteoarthritis who were also obese. And just remind you, you've all seen this slide, almost all of you will have seen this slide before. And our intention was to compare the very low calorie diet with the low calorie diet. And we used these two diets in a large number of individuals, 140 some people in each group, over an 8-week period in which we were giving them the very low calorie diet or the low calorie diet. And what we showed was that we got very good weight reductions of about 12% of the initial body weight in both groups. There was actually no significant difference at 8 weeks, no significance here at 8 weeks. And then also there was no significant reduction after food reintroduction to about 1200 calories per day by 16 weeks. We did this trial for a number of reasons. First of all, to compare the two different diets, showing that really we could use an 800 calorie diet perfectly well. And also we showed that there was a significant pain reduction in both groups. Your experience of helping people who are heavy and have knee problems, I'm sure, is consistent with mine in practice, which is that if you get enough weight loss, you will tend to switch off the pain. That's because you're reducing inflammation in the membrane around the joint and also in the adjacent tissue, and this reduces the pain. It's a very dramatic effect. I've seen some really good improvements in individuals, and it's not just the pain, but also they improve their sleep and they also become more mobile. In Copenhagen, they were able to get back on their bicycles and cycle around Copenhagen, and they're very, very happy as a result of this. A huge increase in, or a huge improvement in quality of life. This trial informed the way that we then went on to do the diabetes trials. So the two questions that I'm asking there are, can we reverse early diabetes with an initial weight loss of 5 to 15% with maintenance as well? And then also the second question, can we prevent diabetes with sufficient weight loss? Now, the answer to these two questions is already known in the sense that we know that if you achieve enough of a weight loss in somebody with early diabetes, you are quite likely to convert them back to being metabolically normal. That has been known for a long time. But what has not been known is whether or not it can be done with a large number of individuals with a method that is acceptable, and then that it can be maintained. And also, is it economically viable? In other words, could healthcare providers actually do this effectively? And that had not been addressed. And these trials had not previously been done with total diet replacement. So these questions were being asked specifically in respect of the use of total diet replacement as the initial intervention prior to long-term maintenance. Some of these slides you've seen already, but I'm going to end with the more recent results. The Diabetes Remission clinical trial was undertaken in Newcastle in northern England and in Glasgow in southern Scotland. And the initial intervention was with an 800 calorie total diet replacement provided by Cambridge Weight Plan. It was a cluster randomized trial based on GP practices. So each practice was randomized. This was so that you didn't get information from one patient being passed to another patient. All the patients in one practice were given either the usual care or they were given the 810 calorie diet. 298 subjects in total completed this trial. It was delivered by healthcare professionals, that is the practice nurses or the community dietitians, using a dietitian-led program, which is one that was developed in Scotland, the Counterweight Plus program, which is essentially all the components that you would normally give in guiding somebody with regard to losing and maintaining weight. You would be asking them about their lifestyle, the pressures on them that determine how and when they eat. You would be asking them about the diet composition that they're currently using, and then you would be making recommendations about how this would be changed, whether on the maintenance program. And you would be asking them questions about why it is that they regain weight after they've lost weight, and trying to think of ways of helping them to avoid that. All those usual things that are in a diet management program. And you can look up the details of that, although actually I just checked, there's not a lot of detail on the website, but at least you know which program they used. So let's move on. Men and women aged 20 to 65 were included. Their diabetes diagnosis was given within the last 6 years, so it was not long duration diabetes. None of these people were insulin treated. They were either just treated with diet alone or diet plus oral medications. Weight range was quite wide. We did discuss this at the beginning, and I suggested that having the very high end was perhaps not a good idea. In Britain and in other European countries, we're seeing an increased number of people with very high BMIs. In the surgical clinic that I worked in until recently, the patients, some of them were very heavy, 150, 200 kilograms, and our heaviest ever individual was 400 kilograms in weight. That is with a BMI of 125. Now, I know that you don't see patients that heavy in Malaysia, but you're drifting in the same direction. And you do see some individuals who are we really need to treat those very, very heavy individuals in a sort of different way. But there were not actually very many very heavy people in this trial. They were mostly in the 30s. The patients were followed for 1 year and 2 years. The results that we have are up to 2 years, but they will be followed for up to 5 years. There's going to be no interim reports at 3 years and 4 years, so we have to wait until 2023 to get the 5-year results. So we just have to wait and see there. But let's see what we've got so far. Well, you know already, because you've seen this slide, the two endpoints that were set were quite high ones, a weight loss of 15 kilograms at 1 year, and in the group treated with total diet replacement initially, 36 out of 149, that's about a quarter of them, achieved that weight reduction. In the usual care group, now this means usual care, the practice nurse gives them the usual guidance that they get in a primary care environment to manage their diet, achieve a bit of weight loss, make the appropriate choices in their conventional diet to get better glucose control and so on. And to include exercise and good quality sleep, all the usual lifestyle things that you would give. And in that group, nobody achieved a 15 kilogram weight loss. The other primary endpoint was remission of diabetes, so the glycated hemoglobin below the 48 millimole per mole level that we define as the threshold for diabetes. And in the total diet replacement group, 68 out of 149, that's 46% of them achieved that and maintained it at 1 year. This is the 1 year results. In the usual NHS care group, there were 6 out of 149 who managed to reverse their diabetes. In normal clinical practice with usual care, if you achieve that, you would be very, very pleased indeed, because we don't normally see that happening. But of course, by using the initial big weight reduction with TDR, a much higher result was achieved, 68 out of 149, and that was a very, very statistically significant result there. So a big change here. And then we look, this slide I've already shown you, I think, about 2 years ago, showing you the relationship between the amount of weight lost and the proportion in that group who were in remission. And there's nothing new phenomenally in this figure here. What it shows is that the more weight that is lost, the greater the proportion of people who achieve remission. So for those who did achieve the 15 kilograms weight maintenance at 1 year, it was 86% were in remission. For 10 to 15, it was 57%. For 5 to 10, it was 34%. A very nice relationship between the amount of weight loss and the diabetes remission. There are other figures in the literature from other trials where there's that same relationship. So we know that the more weight that is lost, the better the outcome in terms of remission. These results actually do show TDR and control combined, but of course most of the cases all of the cases in this group were of course TDR weight loss, and there were a small number of usual care weight losses in this group here, and you can see the numbers at the bottom. So the key message here, when you pool the 10 to 15 and more than 15 kilogram weight losses, you get more than 10 kilograms weight loss results in 73% remission. So 3 out of 4 people in remission at the end of 1 year if you achieve a 10 kilogram weight loss. So that's a very clear, very simple message from this paper at this point. However, there was a lot more detail, of course, and I should say that on all these slides, I give you the link to the paper at the bottom there. When you get the PDF, if you click on that, you will be able to go straight through to the paper. Use of anti-diabetes medications. Now, of course, this was part of the definition of going into remission. And so not surprisingly, in the total diet replacement group, you get a very big reduction in the proportion of them still using diabetes medications at the end of 1 year, and a much smaller figure, a much smaller reduction. It's still a good reduction in the best practice group. However, we also know that there's very good reduction of blood pressure, and that this reduction is maintained to a degree at 1 year. And so there was an inevitable reduction of use of anti-diabetes medication, anti-blood pressure medications as well, and also a reduction in the best practice group. Quality of life, the EQ5 quality of life questionnaire was administered, and there was an 11% improvement in quality of life by that method, and a small decrease in the best practice group. So that is also important. That is also shown where it's been used in other clinical trials in other areas. A big weight reduction results in a big improvement in quality of life. So those results are also really very good results. Now, there are a number of subsidiary papers in the pipeline, and one of the areas related to the use of rescue plans, because in the original protocol for DIRECT, we included rescue plans because we recognize that people regain weight once they've achieved weight loss. It happens. We also have an interesting comparison with the question of our approach to smoking cessation. So when we began to learn in the 1950s and 60s that smoking was not a good thing to do, we tried to stop people smoking, and we developed various programs. And initially, when people stopped smoking, of course, some of them restarted, and then we said, well, oh dear, this hasn't worked, so that's a failed case. But now, of course, what we do is if somebody stops smoking, that's great, we encourage them. But if they restart, we don't dismiss them. We say, try again, do the smoking cessation program again. And we do it over and over again. And we really need to adopt that same process and thinking process in relation to helping people with their weight issues. And so we designed into this protocol weight rescue plans. If somebody regained more than 2 kilograms, they were offered a 4-week food reintroduction program. In other words, we advised them to tighten up their conventional food, but also they had the option to use 1 meal replacement per day throughout that period of time. If they gained more weight and they gained 4 kilograms, then they were offered 4 weeks of total diet replacement. In other words, going off conventional food, back onto meal replacement again for 4 weeks, and then reintroduction of food as was done before. And this interim presentation, which was made at the ECO, that's the European Congress on Obesity, in April of 2019 by one of our PhD students in Glasgow, who's now completed her studies, showed that 50% of people needed 1 or more rescue plans. And so the message from this, on this interim basis, we don't have the full published paper yet, is that we need to plan, if we're talking to a healthcare provider, resources for providing 50% of the participants with some rescue packages, and at least 1 rescue package in the first 2 years. So this helps us to plan the types of intervention that we might use in the future. So that's very important. Now, then we come to the 2-year results. How did these people progress through the 2nd year? They obviously were seeing the practice nurses at intervals, more extended intervals in the 2nd year. Did they regain weight or did they manage to maintain weight? And what I've done here is I've given you the figures for the 1st year and the 2nd year, showing you in terms of remission. And you see that at the end of the 2nd year, those who maintained more than 15 kilograms weight loss, 70% of them were in remission, and those who maintained 10 to 15 kilograms, 60%. So if we pool those two, we can say that for those who maintained more than 10 kilograms weight loss at 2 years, 63% were in remission. And the proportion of individuals who actually did maintain that weight was very high. So we can say that 2 out of 3 individuals maintained their remission. And I've given you the link at the top here so that you can go to the full paper to find more information. I've also summarized it on one of those summaries that I've put on the website. So at this point in time, where we can say about a year ago that we have the data for 2 years, the DIRECT program can be sustained for 2 years, and 2 out of 3 people will maintain their remission. But of course, we have to then say, well, that's great for those who actually did manage to do it. What was the problem with those individuals who weren't able to do it? Was they weren't able to maintain their weight loss? What are we able to find out about those individuals in terms of what was going on in their bodies? What were they as good at adhering to the diet, and all those sorts of questions? Multiple questions are arising. So I've now given you some references to some papers, including this one, which looks at liver fat and pancreatic fat. And this was work done on a subgroup of the participants in Newcastle in the north of England. Those in diabetes remission at 1 year were defined as responders. Those who were in remission had lost 16.2 kilograms, that's 16%, but had regained 3.3. In other words, they lost more and they regained less. Those who did not go into remission, the non-responders, had lost less, if you compare those two figures, but regained more. So we can say non-responders lost less and regained more. And that's very useful because that gives us a clue about the intensity of management, or the intensity of the guidance, the interactions, the frequency of interactions, the frequency with which people come back to you and say, I've gained a bit of weight, I need to do something about it. Those who don't come back to you and tell you, of course, are the ones who are not going to be as successful. And then also, and I know you were just looking at this when I joined the meeting, we now know that there are differences in what happens in the liver and the pancreas. We know that with the big weight losses, you get this dramatic reduction of liver fat, and this not quite as dramatic, but really quite important. There's a question there from somebody. I don't know whether you want to take the question now or later. You decide at your end. There was a reduction of the pancreatic fat as well. And we know that those who were in remission actually maintained their liver fat reduction more effectively. And we now have some evidence that suggests that they maintained their pancreatic fat reduction more effectively as well. And we also know that they maintained their blood ketone levels at a higher level and for longer. So that we know that responders were those who lost most weight, maintained most weight loss, and also maintained their liver fat reduction. Can I just check, do I need to take that question now, or do you want to, because I haven't got anything else coming up here telling me, or shall I just carry on? Carry on?
Yes, carry on,
yep.
Please.
Carry on. Okay, right, fine. We can take it at the end. And then very recently, there was a publication which is really very exciting, which again is from the University of Newcastle, which looks in more detail at the pancreatic changes. And on this slide, what I've given you is the insulin production that is measured by a particular technique that they've done 12 months to 24 months in this bottom panel here. There is a recovery towards normal. Here's a comparison with a normal non-diabetic group of individuals. The scans, very sophisticated scans, very difficult to scan the pancreas and to get images from it. These people are really at the forefront of this scanning technology. You have an example here of what a pancreas is like when they have been developing diabetes over probably 10 or 15 years. And then what you see is the changes in, this is just one individual, of course, on these pictures, the changes showing the improvement over the 2-year period. And then down at the bottom, you see the pancreas, sorry, in the middle panel, you see the pancreas volume, where you see the recovery of the pancreas volume over 2 years. Now, the important thing, of course, is the time scale and the fact that it happens. So, you know, this is the first evidence that I'm aware of, and as far as the research team is aware of, showing this very exciting potential effect. And but it also shows that it is a slow process. You don't get it in the first 5 months. You're beginning to see it at 12 months, and it's more effective at 24 months. But there's still a little way to go towards normality, which suggests that you probably have to go on for maybe 3 years or 4 years before you get yourself back to normal, if indeed it's possible to get back to normal. But it also shows, and this is where we should really be encouraging people with a new diagnosis of diabetes, this is not an irreversible state. If you lose enough weight and you maintain enough weight loss, and you maintain this, you will get possibly. Again, a lot more work needs to be done to work out who can respond well in this way. Perhaps there are some who are more likely to respond and some who are not likely to respond. But it is a really exciting development because there's no other drug intervention, as far as I know, and there's no other bariatric surgery intervention which has actually demonstrated this effect. This is phenomenally exciting. You know, we should be hearing about this on the news every day as being a major potential advance. Anyway, there we are. I'm really excited about it. So is everybody else who's involved, and I hope that you share my excitement with this. So we can now summarize and say that use of total diet replacement as the initial weight loss method can deliver 10 kilograms weight loss in 3 out of 4 people at 1 year, and in 2 out of 3 people at 2 years. This delivers remission. Responders lost more weight or regained less, possibly reflecting tighter energy intake control. Rescue packages were needed in 50% of the responders. Pancreatic morphology is reversible in some of them, and is reversible towards normal. And the question we now have, can this be maintained for up to 5 years? The study continues. But you'll be interested to know that this type of intervention is already in use by the State Health Service, the National Health Service in Scotland. And we now have a rollout in NHS England where 5,000 individuals are trialing this on a regional basis. And if the results come out well, this is very, very good. But there are some supplementary questions that we have to ask, and that is, healthcare providers will always say to you, is this cost effective? But before we do that, there's an important issue, which is, it's all very well, but this study is largely undertaken in Europeans, and what we would like to see is an investigation in non-Europeans. And so I'm pleased to tell you that my colleague Shahad Tahiri, working in Qatar, has undertaken a study which is very, very similar to DIRECT in its makeup, on 107 men and 40 women aged 18 to 50 years who are from the Middle East or North Africa. They'd had their diabetes for a slightly shorter period of time, 3 years. It was a randomized trial undertaken in primary care, and they started with an 800-calorie diet for 12 weeks and then food reintroduction in 70 of the individuals. 77 of them used usual care. And the weight changes you see in this panel here, and they achieved 12 kilograms in the total diet replacement group compared to 4 kilograms in the conventional care group. That's obviously a very, very statistically significant result at 12 months. So a very successful intervention. And then if you look over here on the left, you will see the HbA1c curve showing a big reduction and maintenance of that lower HbA1c, and a good result in the conventional care group, but of course it tends to drift up. So much better results with the TDR. And then you will see the difference between the intervention group and the control group. These are 1-year results, 12-month results, where you have 62% of them going into diabetes remission and 33% of them becoming normoglycemic. So complete normality on their glucose levels there. And over here on the right-hand side, I've given you the medication results for the intervention group: 90% reduction, usual care 11% reduction, antihypertensive 40%, because again, in this group, the blood pressures were improved. So the key message from this trial, and I've given you the link so you can look at it yourselves, is that total diet replacement is effective in a Middle East population, as effective almost, or in fact slightly better in this slightly shorter period since diagnosis in a Middle East population. Why do we need to study different populations? Partly because the pattern of presentation for diabetes is different. In countries which have very good healthcare systems, people tend to be diagnosed relatively early, whereas in countries where a proportion of the population is less able to access good healthcare, it may well be that diabetes is more advanced at the time when they present. So we have to take account of those things. Also, different dietary approaches, different effects of obesity in terms of and distribution of fat in relation to the metabolic changes in diabetes. So it's very important that there are studies in different population groups around the world. So this is a very, very important landmark paper as well. And then we come to the question of diabetes prevention. And there was a trial. There are a number of trials, as you know. There's the Finnish diabetes prevention trial. There is the US prevention trial, a whole range of different diabetes prevention trials across the globe, which have given us the information which enables us to set up diabetes prevention programs within public health arenas. We know that you need to identify the people who are more at risk, those who have perhaps had gestational diabetes or who have a strong family history of diabetes, those who are heavier, older. Age, I'm afraid, is an inevitable factor. But we know that the interventions need to focus particularly on weight loss and also physical activity and also changing the diet. So a lot of information is already known. But despite that, the total number of people across the world who have prediabetes, most of them have no access to a diabetes prevention program. And so we're only touching a very tiny percentage of all the people globally who would benefit from a diabetes intervention program. And so what we need to do is to work out ways of delivering simpler, more effective programs to more people in a cost-effective way. And in order to make progress with this issue, the European Union decided to fund a very large trial on people in 6 European countries and also in Australia and New Zealand. And to do this, nearly 16,000 people were pre-screened, 6,000 had a glucose tolerance test, and eventually 2,224 people started the program. These people had pre-diabetes using the American Diabetes Association criteria, and they were also overweight. They started a 3-year program, but this began, everybody started with an 800-calorie diet for 8 weeks. So 2,224 people started this diet program, distributed around these 8 centers across the globe. And 1,857 people completed the program. That's a 91% completion rate. This is a demonstration of the fact that total diet replacement can be delivered in different countries across the world very effectively, with only 9% of them not able to complete the program. This is a very, very clear demonstration of high compliance. The average weight loss in the 8-week period was 10.7 kilograms. 2/3 of these people were women and 1/3 were men. Women lost slightly less at 10.3 kilograms and men more at just over 11 kilograms. Those who achieved the weight target of 8% that was set in the protocol then went on to the 3-year weight maintenance program, and those who didn't achieve that were then just given general advice and did not participate in the trial. 84% of them achieved that and moved on to the 3-year program. 2/3 of these people were not pre-diabetic at the end of the 8-week program using WHO criteria. We move on to the next one. And what you see here is that 1,857 entered the 3-year program. Now, the 3-year program was based on the Diogenes trial that was published in 2010. And I've given you the reference to that in one of the summaries that I've written, to which I've given you the links right at the beginning, so you can look up the Diogenes paper if you wish. But that was a comparison of a low GI and high protein diet and a higher GI and lower protein diet. So 2 different dietary levels. And then there were 2 different physical activity levels. One was a higher physical activity level and one was a lower physical activity level. And these were applied and offered for 3 years. Dietary records were kept at intervals. They did have targets for the amount of change in glycemic index and the change in protein that they wanted to achieve. And the dietary evidence showed that they didn't, on average, achieve those targets. They got towards them, but they didn't quite get to them on average overall. But of course, there's variation. We haven't yet got a paper which looks at the variation in detail. So what we can say is they moved in the right direction, but they didn't actually achieve the targets. Now, 52% of those who started this completed the 3-year program. And this is actually not a particularly great outcome. We would normally expect slightly higher completion rate. But what is interesting is that of the 962, 64% of them actually developed diabetes at 3 years. Now that is less than was expected by extrapolation from other diabetes prevention programs. So for example, in the Finnish diabetes program, 9% had developed diabetes by 3 years. The 3-year weight maintenance in that trial was between 3 and 4 kilograms. And the US diabetes prevention program, 14% had developed diabetes by the end of 3 years. And again, about 3 to 4 kilograms weight reduction at 3 years. How much weight loss was maintained in this trial, the preview trial, at 3 years? Well, it was between 4.6 and 4.9 kilograms, which represented just over 50% of the initial weight loss that had been achieved. So one of the features of this trial is that the initial weight reduction resulted in a larger weight maintenance at the end of 3 years, which was greater than had been achieved by the other intervention trials that have been done. So what this suggests is that, first of all, it's possible to deliver this in these groups in different situations in different countries. 4.6 to 4.9 average weight loss was maintained at 3 years, which is regarded generally as a good weight maintenance to have achieved, and 6.4% developed diabetes at 3 years, lower than expected. There was also a relationship between the amount of weight maintained at 3 years and the various metabolic measures. However, in this first paper, they didn't give enough information for us to know the precise details of that. And I've been in touch with the principal investigators, and I've been hassling them to produce another paper which will give us more details in that area, because that's very, very important, because what it will almost certainly show is that those individuals who achieved the greatest weight losses and maintained those weight losses were the ones who had the best metabolic state at the end of 3 years. That's probably what we would expect. Now, the next question is, can total diet replacement be delivered in a primary care setting with GP referral into the community? Because one of the key things we have to remember is that if we achieve our objective, my personal objective would be to see total diet replacement accepted globally within all the options that are offered to individuals and to the providers of state healthcare, the providers of private healthcare, the providers of public health, so public health interventions, that total diet replacement be considered as an option to achieve an initial weight loss in either diabetes remission or diabetes prevention. If we were to do that, there would not be enough healthcare professionals to deliver it. So we have to consider how this can be offered. Even in the United Kingdom, we only have, I think it's now 3,000 to 6,000 dietitians, for example. We don't have the healthcare professionals to deliver it. So one option is for medical management, always as it should, to remain with physicians and primary healthcare providers, practice nurses, dietitians, and so on. But the actual delivery of the program can go out into the community. This trial was undertaken in Oxford in order to see whether that was a feasible and cost-effective program. So this is based on primary care at the University of Oxford, with primary care doctors in practices around Oxford referring patients out either to usual care delivered by the practice nurses or to Cambridge Weight Plan consultants delivering the 810 calorie program, followed by maintenance up to 1 year. And the results, I've shown you these before when I was last with you. This is the weight loss curve showing the 4.5 kilograms achieved initially by usual care, which is very good. If that was achieved on all the patients in usual care, that would be great. 3 kilograms maintained at 1 year compared to 15 kilograms and then just under 11 kilograms at 1 year in the total diet replacement group. That is extremely good and a significant difference between the two. Now, interestingly, when this was being designed and discussed with primary care physicians, they were very concerned about how they were going to manage medications, what they needed to monitor, what they needed to do. So bearing all of that in mind, and anticipating doctors' anxieties about medication dosage, the Oxford group have provided online guidance, and this is available. If you click on that link at the top there, it will take you through to several pages of guidance, including a medication adjustment set of guidance. And of course, all those medications which are likely to cause hypoglycemia in a situation where the dietary energy intake is restricted are stopped at the beginning. Metformin can go to half dosage because it doesn't tend to cause hypoglycemia. But if you don't stop those other drugs, obviously there's a risk of hypoglycemia developing. So they have to be stopped as the diet starts. There's a lot of other useful guidance there, and I would recommend those of you who are interested, as soon as you receive this PDF file, which is going to be circulated in a few moments, you can check these pages. Now, the other interesting and very, very important question, because of course in most environments, healthcare providers will not provide interventions that are not evidence-based and evidence-based with good, high-quality randomized controlled trials, but they also expect to see analyses of the healthcare of the costs. They want a proper analysis. Now, this has been done for the DROPLET trial. I've given you the link to the paper there, so you can look at the paper directly, but I've cut and pasted one of the images here because one of the findings was conclusion that overall it was cost effective by the criteria that are currently used in the United Kingdom by the National Health Service and by the National Institute for Clinical Excellence. But as you would expect, the group in which it was most cost effective were the middle-aged and older adults and those in the higher levels of BMI. And I've cut and pasted the figure here. And what you see is as people get older, they get further away from this critical line. The further away you are from that line, the more cost effective the intervention. And similarly with BMI, the greater the BMI, the more cost effective it is. There's no difference between men and women in this trial. So this is actually also in a sense, a landmark paper because it shows absolutely clearly that this intervention is cost effective in the context of the United Kingdom, at least. It would obviously have to be done for each country separately. But is also, if you want to target particular groups, you target your heavier, older individuals. So what we can say on the basis of that is that it is cost effective, but then the other question is, we've only got 1 year results. Well, there is a paper which describes the 3-year results. It was to have been presented at the European Congress on Obesity in March, but that was postponed to September as an online meeting. There was an abstract. It is available online. You can click on that link, which you'll get shortly, to see that abstract. The paper is under review, likely to be out very shortly, and I've just cut and pasted a couple of sentences from the published abstract, which you see here, which is that even without additional support after the initial weight loss intervention, 2/3 of the weight lost initially, or rather I should say the weight lost and maintained at 1 year was still apparent 2 years later. So this is providing evidence that this type of intervention delivered in this setting, which is a cost-effective intervention, can be maintained for up to 3 years. So again, this is a landmark paper which you will see published shortly, I hope. So what we can say is it can be delivered in this way. Now, this is very exciting because obviously much of your work is involved in what would be a setting which would match up to this setting that was studied in Oxford. So this is the evidence that shows you that it does actually work. This is a randomized controlled trial showing efficacy and cost effectiveness and safety, of course, because all the safety data has been published, and that a 10% average weight loss at 1 year is achievable in this setting, and that a good proportion of that can be maintained for 3 years, we now know. So now the next question that we come to is the question of weight maintenance, because clearly there are individuals who are able to maintain weight successfully. Many people gain a little bit of weight, but we know that if you offer them special ways, like the rescue packages used in Direct, you can help more people to maintain a better weight loss. So I'm just briefly going to look at the types of interventions which have been studied and then consider the areas that people are currently investigating. And let's first of all look at Direct. So that had support and guidance from healthcare practitioners on diet and lifestyle, and then there were the rescue packages. If they gained 2 kilograms in weight, they were offered an intensification of the dietary intervention, reinforcement of the messages, but they could also use 1 meal replacement per day. If they gained 4 kilograms in weight, they were offered a 4-week total diet replacement, 800 calorie diet for 4 weeks, and then their food was reintroduced again with reinforcement of the dietary messages. If we look at the preview trial, that was designed to actually test whether there were differences between the different groups. And despite the positive results demonstrated by the Diogenes trial published in 2010, there was no significant difference between the dietary groups and no significant difference between the exercise groups at the end of the 3-year period. Now, they did not achieve their targets either for the dietary intervention or the exercise intervention. So that may partly explain why they didn't show significant differences between the groups. However, all of the groups actually achieved the 4.6 to 4.9 kilograms weight loss at the end of 3 years. That represents just over 50% of the initial weight loss. We don't have internationally accepted criteria for successful weight maintenance, but the literature at the moment suggests that we're thinking in terms of if you achieve 50% of your weight lost initially at 2 or 3 years, that represents success. So by criteria not yet formally defined, we would probably think that this would be a successful outcome. And of course, you could say that it's also successful in the sense that there were a smaller number of people developing diabetes over 3 years than was expected based on previously published evidence. So it will probably require more investigation, but we can say that the preview trial provided the evidence that an initial good weight reduction is probably a good thing to do in a diabetes prevention program, probably for all the same mechanistic reasons as apply when we're studying diabetes remission. I've asked the people who are running this trial to very quickly do the analysis on the relationship between weight loss and the metabolic parameters. And so I would expect that to come out within 6 months. Now I want to go back to the Copenhagen osteoarthritis trial, because although I just showed you just one slide, we did, as all of you know, because I've shown you these results, or many of you know because I've shown you the results before, go on to a dietary intervention compared to an exercise intervention, and then eventually a 1 meal a day versus intermittent total diet replacements. And the results figure you have seen before. And as a result of that, 2/3 of them maintained 10% of their body weight for 3 years. And this trial, which is published, and I've given you the link there at the top, showed that, remember, they have lost 12% of their body weight from about 104, 105 kilograms before this point here. So this is a weight maintenance study. It's not a weight reduction study. These figures are the dietitian's office results for those who used 1 meal replacement per day. These are the ones who did the intermittent total diet replacement. And you could say, well, I don't like the look of that because they're going up and down, and we think that going up and down is not a good idea based on studies like the Framingham study. The answer there was the concern about cardiovascular risk, and what I can tell you is that the cardiovascular risk profiles at the end of this were not significant difference between these two groups, and the lean body mass losses were not significantly different. The amplitude here is only 2.5 kilograms, which is much less than the 10 to 12 kilograms amplitudes that were shown in the Framingham study to be associated with, possibly associated with, increased cardiovascular risk. However, the key figures here are the ones observed by the nurses working in the clinical research unit who were unaware of the treatment group. And that showed that there was no significant difference between the groups at the end of 3 years. One group had risen by about 0.7 and the other one just over, or 1.7 kilograms, I think. So what we can say from that is that in this particular group, in this setting, in these older people with knee osteoarthritis in Copenhagen, weight maintenance was achieved on average either by one meal replacement per day or intermittent use of total diet replacement. Now, of course, within the groups here, an average tells you what the average did. There are those who achieve better results, those who achieve less good results. There are different behaviors. Some people lost more weight initially, some people lost weight during this maintenance period. But we can say that on average, these are the outcomes. Now, there's more analysis being done on the detail from this trial, and it will make a contribution to our understanding of what are the good ways of achieving weight loss maintenance. But it is interesting that one of the ways is to say, okay, you use total diet replacement just for a short period of time, maybe 8 weeks, maybe 12. In the direct trial, it was 12 to 20 weeks. But you don't just say after that, you just follow your usual diet, do all the right things. People will need some help, or some people will need some help. They will need either reinforcement of the dietary guidance. They may need to use 1 meal replacement per day. They may need to use total diet replacement for short periods of time to get a few kilograms weight reduction. So we need to consider that all of these options are there. So that's where we are at the moment. And so to summarize, I think what we can say is that we have situations globally where there is rising prevalence of type 2 diabetes and pre-diabetes. Total diet replacement offers a potential gap in our offering at the moment. What can we offer in some countries? We offer conventional diet, which generally isn't particularly effective in the long term, or we offer bariatric surgery. We're not going to be able to offer bariatric surgery to most people. We can't certainly offer it to everybody who develops diabetes. So we've got to have something in the middle. Conventional diet delivers a few kilograms weight loss. Bariatric surgery can deliver 20, 30, 40 kilograms weight loss, but we need something in the middle, which is effective, safe, proven to work, and proven to be cost effective. One of the key things about total diet replacement is the fast weight loss, 1.3 to 1.5 kilograms per week, which is motivating. In my practice, I've seen individuals who are highly motivated by the reduction in weight, the improvement in mobility, the improvement in sleep. There are published trials on obstructive sleep apnea, which often goes with diabetes. And there are many people walking about who have obstructive sleep apnea who don't really realize it. I have arranged for some of my colleagues in Copenhagen to study sleep in individuals who do not have obstructive sleep apnea, because I've long felt from talking to patients that even when people do not have obstructive sleep apnea, their sleep may well be improved by weight reduction, but we don't have the scientific evidence. I'm hoping we'll have that by the end of the year. Total diet replacement can be delivered in specialist, primary care, and community settings. It's very important that we look at different settings. We've done that. Compliance is high, 91% in preview. The safety profiles are good. We can discuss those in a minute if you wish, but they're all published. Reduction of medication costs as demonstrated in direct. It's cost effective as demonstrated both in direct and in droplet. So what are the next steps? You can produce all the first-rate clinical trial evidence in the world, but if nobody takes any notice, you're wasting your time. So the next step is to work towards getting the evidence reviewed by expert committees and incorporated into clinical guidelines where it's appropriate and if they think it's appropriate, and then also to address the need for education of healthcare practitioners so that they know the science behind the intervention, and that they also have experience of seeing some of their patients lose weight in this way. And my experience in NHS practice in the UK is that I only needed to demonstrate in 1 or 2 patients with big weight losses, and general practitioners were then very convinced by seeing a few examples. They were really convinced that this was an important type of intervention. And so finally, we then move in the last few minutes to considering where we are going now in terms of thinking about what we need to do. We need to bear in mind physiological factors. We need to give our interventions in a way which results in the least loss of lean mass, because lean mass loss determines the baseline resting metabolic rate during weight maintenance. So we need to retain as much lean mass as possible. And we know that the dietary composition with sufficient protein and also the use of exercise, including resistance exercise, is important in maintaining lean mass loss. But we can also tell you that the lean mass losses in the clinical trials is not as great as the literature would have suggested in the past. We need to identify the characteristics of poor maintainers. What are the characteristics of those who have difficulty maintaining their body weight? We know, and it's published already, that low baseline GLP-1, the hormone release from the lower gut, if they have lower baseline levels, it's likely that their appetite is driven more strongly. Therefore, they may maintain weight less well. We've got a paper which is not yet, actually it has just been published just a couple of days ago, which shows that ghrelin is also an important variable, and those who produce a higher rise of ghrelin after an initial weight loss are less likely to maintain weight. So we know that ways of controlling ghrelin need to be thought about very carefully. We know that behavioral factors play a part, particularly in the heavier individuals. We know that those who are impulsive and who see something they like and eat it, whereas others may be able to resist that inclination to eat. Those who are more resilient, the stresses of life may be easier for some people to cope with than others. The need for support is greater among some people. Some people may need to be talking to somebody twice a week. Others may be quite happy to be told or advised what to do and then don't want to see you again for a month. There's variation in the behavioral factors. And then finally, dietary variables. We know that energy density is important. We need to keep the stomach full with low energy dense foods as much as possible, because that can influence ghrelin. Satiation signals, thinking of ghrelin again, and GLP-1 are important. And how do we manipulate those? Well, now, of course, there may well be a place for the pharmaceutical industry to help us here by producing GLP-1 agonists, and indeed those are already available and are used for people with diabetes and are beginning to use in people who are uncomplicated individuals with weight loss problems. However, they are very expensive and not without side effects, but they will be used increasingly. We need an anti-ghrelin compound for some individuals. That's not yet available as far as I know. So these are the things that are being thought about and developed at the present time. So that concludes what I have to say, and it gives us a few more minutes now for some discussion, but I'll end with that summary slide. So thank you very much for listening to me.